morning to all of you. As Sir already told, actually I'm a cardiologist. I did my MBBS from Pondicherry, then did my MD medicine. After that, then EMD cardiology from CMC. So last 10 years I'm practicing out here. So today, as part of the early clinical exposure, I would like to talk to you regarding acute myocardial infarction. So to begin with, heart is an amazing organ because you know at what age of life the heart starts beating. Any guesses? Pardon? Maybe a bit louder. It's too late. It starts from 3 to 5 weeks of fetal life. So it starts as early as 3 to 5 weeks of fetal life and it beats all throughout our life till our death. So it is an organ which is exclusively important for all of us. It weighs around 50 to 400 grams. It beats around 60 to 100 per minute. So 60 to 100 beats per minute, that you can calculate per day how many times is beating per day. So acute myocardial infarction means, in clinical term, it is known as acute myocardial infarction. Do you have any idea what does it mean, acute myocardial infarction? Any idea what is meant by acute myocardial infarction? In normal term, in layperson's language, it is known as heart attack. Yes, precisely. So layperson's language, it is known as heart attack.
When I started my practice some 20 years before that time, myocardial infarction was a disease which was not that prevalent, and it used to happen to individuals who are 60 or 70 years old or older to that. But in today's world, especially last 15 or 20 years, 10 to 15 years, the myocardial infarction is happening very, very commonly, and it is happening to very young individuals also. In fact, it's not uncommon to see myocardial infarction happening in a 25-year or 30-year-old fellow. It's very common nowadays, 30 to 40 years old fellow. So myocardial infarction, first of all, is very prevalent. It is gaining more and more prevalence in today's world because of so many reasons that we won't discuss today. Maybe for some other classes we'll discuss that. And it is not only becoming more common, it is also becoming very prevalent among the young persons who are apparently healthy, but suddenly they collapse on the ground. You would have heard that through various media, that suddenly, even a few celebrities also, suddenly they collapse on the ground and they succumb. So that's why it is important to know about acute myocardial infarction, bits and pieces, because your first years, you recently have started your journey to become a doctor. Now that you have started with anatomy, physiology and biochemistry, probably you are not very much aware about pharmacology, pathology, microbiology and clinical medicines. So today I am going to touch briefly about what is myocardial infarction and how to diagnose it. Especially I would like to talk to you regarding what is the importance of history, because history is something which is very, very important. So, coming to myocardial infarction, basically it is the blockage of the coronary arteries. So, what are the coronary arteries? Have you been taught in the anatomy, the coronary arteries? Have you been taught? No. The coronary arteries are the blood vessels which supplies the heart, because heart is a beating organ which keeps on beating right from the birth, even before birth, as I have already discussed, till our death. So, it always beats. So, in order to beat, it requires energy, doesn't it? As we walk or do our daily activities, we require energy, isn't it? So, how do we get our energy? We get our energy through food. We take food, and through that food, we get energy so that we perform our day-to-day activities. But heart, as it is beating always, it requires energy, and that energy heart is getting through its blood supply. So heart basically is a pumping station which pumps blood all throughout our body. It supplies blood to our brain, it supplies blood to our GI tract, our upper limbs, lower limbs, all parts of the body. And in order for the heart to pump, heart has its own blood supply which supplies the nourishment to the heart muscle. So these are known as coronary arteries, and there are 3 coronary arteries. Left side there are 2 coronary arteries mainly, and right side there is a 1 coronary artery. So right sided coronary artery is known as right coronary artery, RCA, right coronary artery. While left sided coronary arteries are known as, I'll show you. See, this is the heart, okay, and this is the heart muscles, and this red things are the blood vessels of the heart, which are known as the coronary arteries, which supplies the nourishment to the heart. Okay, so there are 3 blood vessels mainly. On the right side of the heart, there is a right coronary artery. As it arises from the right side, it is known as right coronary artery. From the left, it is known as left coronary artery. So left coronary artery, there is a main artery which is known as left main coronary artery, or left, it is known as LMCA, or left main coronary artery, which divides into 2. One is left anterior descending artery, which is known as LAD, left anterior descending artery, and another is left circumflex artery, or LCX. So this is basically anatomy. You would be taught in due course of time what is the anatomy of the heart, what are the blood vessels of the heart. So to prime you, I have told that heart is an amazing muscular organ which keeps on beating always. For that, it requires nourishment, and heart gets its own nourishment through its blood vessels, and these blood vessels are known as coronary arteries. And there are 3 main coronary arteries. Right sided, that is known as right coronary artery, or RCA. In the left side, there is 1 main coronary artery which is known as left main coronary artery. This one, left main, which divides into 2 branches, left anterior descending and left circumflex. Left anterior descending artery, also known as widowmaker's artery. Why? Because most of the time myocardial infarction, if it involves the LAD, this artery, what happens? The prognosis is quite bad. Usually patient die because of the involvement of this artery. So that's why it is known as widowmaker's artery. So when you give your exam, NEET exam, PG exams and all, there is an MCQ which is known as widowmaker's artery. The answer is the left anterior descending. This is the left anterior descending artery which is known as widowmaker's artery. So myocardial infarction happens when there is a blockage inside that arteries. Understood? As I have shown in the inset. So this is the magnified view of the vessels, where this is the blood vessel. Normally the blood vessel, there should not be any blockages. It should be smooth and blood should be flowing very normally without any turbulence. But because of a faulty lifestyle, because of smoking, drinking or unhealthy lifestyles, too much of junk foods, fast foods, stress, lack of sleep and so many other conditions, diabetes, hypertension, all these are risk factors for coronary artery disease, where because of these risk factors, what happens? Slowly there will be accumulation of these fatty substances inside the blood vessels. Understood? So that is only known as blockages. It's something like a pipe. When you see a pipe, normally a pipe should be smooth, there should not be any obstruction inside the pipe, so that the flow of water should be normal. But if there is some obstruction, as it's shown out here, there is a plaque formation. Plaque basically means fatty deposit which gets deposited inside the blood vessel. So what happens? The lumen of the artery gets narrowed. You can see this is the normal segment of the artery which is wide, there is no obstruction. This is also normal segment, but out here you see there is a plaque formation, there is a fatty substance which gets deposited inside the blood vessels. So what happens? The lumen is the inside portion of the vessel which gets narrowed. So this is wide, isn't it? This part is the wide, but this part is narrowed because of this block. So this is basically a coronary artery disease where there is a blockage inside the coronary arteries. So whenever there is a blockage in this coronary arteries, what will happen? Patient will complain of chest pain. Understood? So very commonly patient will complain of chest pain. And any branch of medicine or clinical medicine, you should be able to take a proper history. That's the importance of taking history, because investigations are there. Obviously, physical examination is also there. But first and foremost is the art of history taking, because if you take a proper history, most of the time you can diagnose a disease by going through a proper history. Then obviously physical examination is important, followed by investigations are important, blood investigations and radiologic investigation, various investigations. But in clinical medicine, first and foremost is the art of history taking. So commonly the coronary artery disease, the patient comes to you with a chest pain. Understood? So how would you take the history of chest pain? And there are a few typical symptoms the patient will complain of when the patient is having a cardiac cause of chest pain. All the glitters are not gold. Likewise, all chest pain is not cardiac. There can be so many causes which can lead on to chest pain. We tend to see so many patients in the OPD setting where the patient comes to us chest pain, but not all of them are having coronary artery disease. Understood? Few will be having probably gastric disorders like peptic ulcer disease. Few will be having a gallbladder disease, cholecystitis. Few might be having some musculoskeletal problem. Few might be having a lung problem like pneumonia. So chest pain doesn't always mean the patient will be having a coronary artery disease or heart disease. Chest pain could be because of anything. So that's why it is important to understand and to take a proper history. So typically when a patient is having a heart disease and when he complains of chest pain, this chest pain has few important characteristics. So what are those characteristics? Patient will complain of, where is the pain? Patient will complain, usually pain is in the middle of the chest, in the sternum. Have you heard about the sternum? Anatomy they have taught you sternum? What is the sternum? Pardon? The bone out here in the middle of the chest, which is sternum. So retrosternum means behind the sternum. Retro means behind. So in coronary artery disease or those patients who are having a heart blockages, the chest pain will be typically behind the sternum, retrosternum. So patient will complain the pain here, not here. Okay, so retrosternum. And patient will complain the pain is, the character of the pain will be like heavy, squeezy, sort of like a pain, not like a pricking pain. Understood? Or burning pain. More of the time he'll complain the pain will be heavy or squeezy, as if some elephant is sitting on his chest. So heaviness feeling, constricting feeling, retrosternal. And it will be aggravated by exertion. Whenever he walks, maybe on the level ground or taking few stairs, whenever he exerts himself, he has pain. Or whenever he is having not only physical exertion, probably an emotional exertion also. Like if he's hungry or angry or emotionally very stressed, that time also he can have the chest pain. So precipitating event. So these are very important. So in medicine, clinical medicine, the art of history taking is very important, and you take history taking based on few pointers, like as I have told you. And these pointers I remember as an acronym as a STAR, S-T-A-R, STAR. In my first year, I was told in that way, in my first clinical posting in my medical college, as how to take history. And out there I still remember and I still use it in my clinical practice whenever I encounter a patient, because patient will come to you, isn't it? You will pass out, you might be in any specialty, you could be doing a general practice, or you might be an internal medicine fellow. You might be a gynecologist, you might be a pediatrician, you might be an orthopedics, you might be even cardiologist also. But whichever field you are in, patient will come to you with symptoms. Understood? That means patient either will come to you with a chest pain or headache or abdominal pain or some symptom or fever. Understood? Or shortness of breath. Patient always will come to you with symptom. Understood? And it is important for you to take a proper history, because if you take a proper history, you'll be able to pinpoint your diagnosis or narrow down your diagnosis to a few 2 or 3 conditions. And from then onwards, you can do few investigations, you do a physical examination, you do few investigations, and then you come to a conclusion that patient is having this disease. So that's why time and again I'm telling you, there is so much of importance or emphasis should be on proper history. And regarding symptomatology, the STAR acronym actually, especially for pain. See, patient will come to you with chest pain, or he might come to you with headache, or he will come to you with abdominal pain, because pain is something which is one of the most common symptom for which the patient presents to your doctor. Pain anywhere in the body. Understood? So you should be able to understand this pain, the patient is complaining of abdominal pain, whether this abdominal pain is because of appendicitis or cholecystitis or pancreatitis or maybe because of cardiac issues. It could be anything. Understood? So unless and until you take a proper history, you won't be able to figure it out. Understood? So regarding that, this proper taking of patient's history, especially symptomatology, the STAR acronym helps, where S, T, A and R, where first S stands for sight. You can write it down. First, this thing stands for sight. Where is the site of the pain? Like patient comes to you with chest pain. Where is it? Whether it is a retrosternum, whether it is left side of the chest, right side of the chest, in the epigastrium, or on the sides, where it is, site of the pain. Same thing applies to abdominal pain or whichever condition the patient comes to you with. First is site. Where is the site of the pain? Same thing with the headache also. If the patient comes to you with a headache, where is the headache? Whether it is a global headache all throughout your head, or frontal headache, front part of the head, back side of the head, or side of the head, where is it exactly? So site is very important. Next S is severity. So severity is something which is quite individualistic. It is subjective. Subjective means same pain symptom one would perceive as a severe, and same pain somebody else would perceive as a mild, isn't it? It's subjective because all of our pain threshold differs. Understood? So that's why rather than asking a leading question, how severe it is, you should ask indirectly, non-leading question. In clinical medicine, you should always ask a non-leading question most of the time. Do you understand what do I mean by leading and non-leading question? Leading means, suppose somebody comes to me with pain, abdominal pain, and I ask him, how severe is the pain? So that is very subjective. Somebody might be having small amount of pain, some degree of pain, but he'll be writhing in pain because he is very much pain sensitive. On the other hand, another person might be having same amount of pain, quite a significant amount of pain, but he is still stable. He is telling, no, pain is not that much. So our pain threshold differs among all of us. Understood? So that's why it is better not to ask any leading question. So how do you ask the question? If you are not asking a leading question, you can ask that, you can tell on a scale of 0 to 10, how much is your pain? That is known as visual analog scale. Understood? So you can ask him, suppose I give you a scale of 0 to 10, 0 is least painful and 10 is most painful. How do you rate your pain at present? And you can ask him when the pain had started, how it was, and now at present, how is the pain? Suppose the pain had started one day before. So one day before, how was the pain? And now, how is the pain? Whether there is any change or not. So that is something which is very important. If the pain is improving, then they would say, no, when I started the pain yesterday, the pain was significant. It had hampered my day-to-day activity. But now it is not hampering my day-to-day activity. So that means it is coming down in severity. So you can ask an indirect question like that, whether the pain or whatever ailment the patient is having, whether it is hampering his day-to-day activity. Suppose I am having a pain, abdominal pain. If it is mild, it won't hamper my day-to-day activity. No, I can take classes normally, isn't it? Or see patients or do surgeries normally. But suppose it is so severe that I cannot carry on my day-to-day activities. I cannot give lectures, I cannot see patients, I cannot do surgery. That means it's severe. Understood? So likewise, you can ask from the patient that amount of discomfort or any symptom that he is having, whether it is hampering his or hers day-to-day functioning. If it is not hampering day-to-day functioning, that means it's not that severe, isn't it? So likewise, you can go forward. So once S is site, where is the site of the pain? Second is severity. Then T. T stands for timing. When does it happen? Because there is some pain which happens during a particular time of the day. Understood? Like peptic ulcer disease. That all these things you'll learn later on in due course of time when you encounter different subjects like pathology, pharmacology, microbiology, clinical medicine and others. Just a broad picture I'm giving you. So few diseases are like happens during a particular time. Suppose a peptic ulcer disease, gastric ulcer. So it would happen after taking a food or something like that. So timing, what time does it happen? What time of the day does it happen? Some headache happens during night time. So something like that. What time of the day it is happening? Next is type. What is the type of pain? Suppose patient comes to me with chest discomfort. So I would ask him, where is the site? I will ask him what is the severity, like when it started, whether it is affecting his day-to-day activities or not, hampering his day-to-day activities or not. Then I would ask him the type of the pain. What do I mean by type of the pain? Every pain has some characters. Okay, as I have discussed, the pain of myocardial infarction or heart attack, patient usually complaining of heavy constricting pain, squeezing, heavy constricting pain. On the contrary, if the patient is complaining of like pricking pain, then it's unlikely to be cardiac issues. You're getting my point. So the type of, the character of the pain is also important. It's not only regarding heart, I'm telling. It is for applicable to everything. Whenever you take a history, you should take, like in your surgical posting also, whenever you are asking some patient regarding abdominal complaints, abdominal discomfort, you should follow along these lines. What is the type of the pain? Whether it's a burning pain, squeezing pain, constricting pain, heavy pain, pricking pain, what type of the pain it is. Okay. T gone, then A is for aggravating factor. Aggravating factor. What do I mean by aggravating factor? What do you mean by aggravating factor? Pardon? What aggravated that symptom? Suppose the patient is coming to me with chest discomfort to my OPD. What prompted his chest discomfort? Whether walking prompted, running prompted, or some emotional event prompted. Understood? What prompted his discomfort? For abdominal pain, whether any food, after intake of some food, it prompted the pain or discomfort. So what aggravated the problem? Understood? So aggravating factor is also very, very important. Aggravating factor. Another is associated factor. So what is associated factor? Along with that symptom, what all other symptoms the patient is having? As for myocardial infarction or heart attack, patient will complaining of chest discomfort, but along with the chest discomfort, if the patient is complaining of also shortness of breath or giddiness or perspiration, diaphoresis. So these are all associated factors. So that indicates probably I am dealing with a myocardial infarction. Understood? So in myocardial infarction or MI or heart attack, patient not only will complaining of pain, which will be typical, which will be retrosternal, mid part of the chest, could be precipitated by any physical exertion or emotional exertion. Character of the pain would be like heavy, squeezing, burning sometime pain, and it will be associated with, one is associated with dyspnea, that means shortness of breath, or perspiration, that is diaphoresis. Okay, sometimes it could be associated with confusion, giddiness, and sometimes with syncope or loss of consciousness. So these are aggravating factor. So in all other medical field also, whenever you take history, so that's why if you take history along these lines, you won't miss out anything. You're getting my point? So this is aggravating factor. Second was the associated factor. Then what about R? Relieving factor. What is relieving factor? Like what has prompted the discomfort or pain? What is prompting the relief of the pain? Understood? Like in cardiac disease or heart blockages, what happens? Whenever the patient exerts himself, either physical exertion or emotional exertion, there is pain. But when patient takes rest, then the pain disappears. So the rest is the relieving factor. Understood? So rest is the relieving factor. Likewise, suppose abdominal pain, some gastric ulcer disease, food has prompted the pain. Whenever the patient takes food, he complains of chest pain and abdominal pain. So that is the aggravating factor. Food, spicy food and all those things. And what is relieving factor? Suppose he takes antacid, he gets relieved. So that is a relieving factor. Or he takes some water, gets relieved, that's a relieving factor. For cardiac issues, heart blockages, exertion, physical or emotional exertion causing pain is an aggravating factor, while taking rest or taking some medicine like nitroglycerin that you would learn in pharmacology. Nitroglycerin is a drug which you use for angina. Angina means chest pain. So if the patient is taking nitroglycerin and it is getting relieved, that is a relieving factor. So that is important, the relieving factor. What causes the relief of the pain? In case of cardiac disease, is the rest and nitroglycerin which relieves the pain. So if it is like that, patient gives a typical history like that, then you can be more or less certain, okay, I am dealing with probably a heart issue, not any other issue. You're getting my point? Okay. So R is relieving factor. One R is relieving factor. Another R is radiation. What is radiation? Yeah. So pain originated from here, but it's not only localized out here, it is going here and there everywhere. So in cardiac patients, those who are having a heart disease or heart attack, as I have told, the site would be here, predominantly retrosternum, but it is not only localized to retrosternum, it will radiate to other places. Like typically, it will radiate to the neck, jaw, left arm, left shoulder, especially the ulnar border. Okay, you would have heard ulna and radius and ulna, isn't it? Radial border and ulnar border. Radial border is this side, ulnar border is this side. So cardiac pain, the patient will have pain out here, retrosternum, but not only it will be remaining at the retrosternum, it will be radiating to other parts of the body also, especially neck, jaw, shoulder, left arm and ulnar border of the left arm and forearm. Okay, so this is the radiation. So if you take a history like that, unlikely you are gonna miss out anything. So you can fit typically all those symptoms of heart attack or myocardial infarction. So as you can see, this gentleman, he is complaining of pain, isn't it? He is complaining of pain and he typically places his arm or palm on the chest, middle part of the chest. That means he is having a retrosternal pain, isn't it? And that pain is like heavy, squeezing, burning, all this type. And see, he is perspiring also, isn't it? That means he is having a diaphoresis or sweating, which is an associated factor. So they not only will have a pain which is localized to the sternum, but they will also complaining of shortness of breath, perspiration, sometimes giddiness, vomiting and all this, sometimes abdominal pain also. So sometimes it's very difficult to understand whether you are dealing with a heart attack or gastric issues, because heart attack patients also can have gastric symptoms like nausea, vomiting and all this stuff. Understood? So these are the typical patient who is having a coronary artery disease or myocardial infarction will present like that. Okay. So as I have told you, the character of the pain is very important. Understood? What was the character of the pain? Usually, the character of the pain will be like central chest pain, retrosternal, pressure, squeezing, heavy, tightness, and exertional or stress related. If all these things are there, left-sided, dull, aching, if all the things are there, it is likely to be a cardiac cause. Retrosternum or left-sided, heavy feeling, squeezing feeling, tightness feeling, which is precipitated by emotional or physical exertion, relieved by rest or nitroglycerin, associated with diaphoresis, that means sweating, shortness of breath, nausea and vomiting, giddiness, all those are likely to be a cardiac cause of chest discomfort, or a patient probably is likely to have an myocardial infarction. On the contrary, if the character of the pain is sharp, as if it's very localized pain, usually myocardial infarction pain will be like diffuse pain. Patient won't be able to localize that pain. It will be diffuse. But if he's telling that it's sharp, that means he can localize with his fingertip. Very commonly patient comes to us. They tell they are having a chest discomfort, but usually at the same time they also tell that pain is very localized. They can localize the pain with their fingertip. That means it's unlikely to be a heart issue. You're getting my point. So that's why the character of the pain also matters. Then it is fleeting. That means the pain comes, hits and goes. It's very transient. It probably stays for a few seconds and goes off. Heart attack pain usually it is usually happens over a period of 15 minutes, 30 minutes, 35 minutes. It won't go off just like that. But if it is a non-cardiac pain, the pain will be for a very short period of time. For maybe for a few seconds, pain will be there, localized, then it will go off. Then you can be sure that probably the pain is non-cardiac. Understood? So these are the few important symptomatology where you should ask from the patient. So this is the typical picture of a patient who is having a myocardial infarction. This is from the Netter's diagram. Do you have Netter's, by the way? Have you heard of Netter's? During our undergraduate days, we used to have this Netter's. Netter's used to have a very illustrative, pictures. It used to be so nice pictures. Is it still available, Netter's? Okay. So this is from Netter's, where the patient is clenching his chest and is coming out of a restaurant in a snowing condition. That means it's likely to be having a heart disease or heart attack. See, this is the pain. Pain is localized out here on the retrosternum and is radiating to the left side of the arm ulnar border. This is a typical of cardiac cause of chest pain. So what are the symptoms of myocardial infarction? As I've already discussed. So it's a pain or pressure or discomfort in the center of the chest. Pain or discomfort in other parts of the upper body, including the shoulders, arm, back, neck or jaw. That means it's radiating. It's not only localized out in the retrosternum, it radiates to other parts of the body, especially the neck, jaw, left side of the shoulder, left upper arm, ulnar border, and sometimes the interscapular areas also. Along with that, the patient will have an associated factors like shortness of breath, diaphoresis, nausea, vomiting, dizziness, all these features. Shortness of breath, vomiting, sweating, and sometimes patient might as well faint, because quite a few number of patients comes to us in a condition where they have fainted, but ultimately when you see, they are having a heart attack. So chest pain is not always secondary to heart attack. There are other causes also which can lead on to chest pain. As I have already told you, what could be the other causes which can lead on to chest pain? What could be the other causes? Pardon? Be louder, I cannot hear. Peptic ulcer, yes. Very good. Very good. So you can, system wise you can go. As you have told, gastro. So gastro, that means peptic ulcer disease, either gastric ulcer or duodenal ulcer, gallbladder problem, cholecystitis, gallstone, pancreatitis, So all these gastric issues can lead on to chest discomfort. Okay. Then any other cause? Any pulmonary cause? Pneumonia can lead on to, okay, pneumonia, bronchitis, pulmonary embolism. That I won't go into the detail because you won't understand at this moment of time. Any other things? Musculoskeletal. Okay, you can sit down. Musculoskeletal, like any trauma to the chest can also lead on to chest pain. Okay, so there could be various causes of chest pain. So always those patients who are coming to you with a chest pain, it doesn't mean the patient is having a heart disease or coronary artery disease or MI. It could be anything. So that's why the importance of proper history taking is very, very important. So next time, I think whenever you go to the clinical posting side, you will remember that history is something which is very, very important. At least spend first 15 minutes on taking history, proper history, as I have given in this acronym, STAR, STANR. Another things you should always keep in mind while taking history is, along with this, is onset, duration, and progression. As I have told you previously, patients will come to you with symptoms. Patient will come to you with chest pain, patient will come to you with abdominal pain, patient will come to you with headache, patient will come to you with shortness of breath, patient will come to you with fever. So these are the symptoms he will come to you. Patient won't come with a diagnosis on it. I am having heart disease, I am having gallbladder disease. Patient will come to you with symptom. So it is, the onus is on you to find out what is the cause behind his symptom. Whether his abdominal pain is because of gallbladder issue, whether it's because of appendix issue, whether it's because of cardiac issue or whatever it is. Understood? So that's why the importance of history is very important. After taking this, you should take this history also. Onset, duration, progression. Onset means how the disease had started, whether it is sudden onset or insidious onset. Very important. Because few diseases are sudden in onset. Like suppose somebody is having a heart attack. He will tell, till now he was absolutely fine. He was jolly good. He was roaming here and there. But suddenly he started having the pain. The onset is sudden. Understood? The onset, what is the type of onset? Whether sudden onset or insidious onset, means gradually. In few other conditions, patient will give you history that this discomfort didn't happen suddenly. Slowly, gradually it happened over a period of hours or days. So what is the onset of the symptom of the patient? Whether it was sudden in onset or whether it was insidious in onset. Second is duration. How long has the disease been there or symptom been there? Whether it was there for a few hours, whether it was there for few days, or it was there for few weeks, or it was there for few months or years. Because it matters. Myocardial infarction won't go for days and months, isn't it? It will be very, very short, because patient will be so symptomatic, he will come to you. Any myocardial infarction will come to you within a matter of hours to days, maybe few hours, maybe one day also. But few other conditions like fever, he might come to you. Suppose patient is having a fever because of whatever reason, he might come to you after maybe few days or after 1 or 2 weeks. So it is important to ask from the patient how long has the symptom been there, duration of the disease. Understood? And according to that, whether it is recently it has started or it is long-standing disease. So duration is important. And last is progression. Progression I have already touched upon. What do you mean by progression? What do you mean by progression? Progression means when the disease started, how was it? And now when the patient has come to you, how is he? Understood? Suppose the patient is having a chest discomfort for last 2 days. So 2 days before, when the patient had started the disease, how it was. And now that he has come to you after 2 days, how it is. So if you ask a leading question, as I have told previously, that how was the severity previously and how is the severity now, he might mislead you. Understood? So rather than asking a leading question as how was the pain when he started and how is the pain now, he can ask a non-leading question like, okay, he had the pain 2 days before the pain had started. So during that time, whether you could do your day-to-day activities, whether you could walk for 2 kilometers, then probably he was telling, okay, 2 days before my pain started, but the pain happened so much so that after walking 2 kilometers or beyond, I used to get the pain. Now, after walking for 500 meters also, I am getting the pain. That means what? That means the disease has progressed. Disease has worsened, isn't it? Previously, after walking beyond 2 kilometers, he used to get the pain. Now, after a few days, after walking for 500 meters only, he is getting the pain. That means the disease has progressed, worsened. So that is the indirect way of asking from the patient as how the disease has progressed, rather than asking directly from the patient whether it has progressed, whether it is improved or worsened. Understood? So you should always indirectly assess from the patient how he has progressed, whether he has worsened or he has improved. So that's why the onset, duration, progression is there, very important as far as history taking is concerned. Along with this, the STAR acronym actually is helpful in any sort of pain, be it headache, be it abdominal pain, be it chest discomfort or whatever it is. I hope you are understanding. Any difficulties in understanding? So after that, you diagnose heart attack by taking a proper history. Now I think next time a patient comes to you, you would be able to take a good thorough history as how was the pain, where it started, whether it radiated or not, what precipitated the pain, what relieved the pain, whether there was an associated diaphoresis, whether associated shortness of breath, whether associated vomiting and other stuffs, all these things we should be able to ask. So after history taking, I would talk something about few investigations as well. Because heart attack you cannot diagnose only by history. Okay, you can have your index of suspicion, the patient is mildly likely to have a heart attack, but at the same time you should do investigation, and what foremost investigation in this regard is taking an ECG. So this is an ECG. So ECG is a device which bedside is available, you can easily take, and basically is a graph. What is basically an ECG? Pardon? Is a graphical representation of the electrical activity of the heart. If somebody asks you what is an ECG, ECG is a graphical representation of the electrical activities of the heart. Okay, heart is having an electrical activity, isn't it? And that you capture by doing an ECG from inside of the heart to the surface of the heart. So there are various electrodes which are fixed on the chest wall. And not only chest wall, there are a few electrodes which are placed on the extremities, upper limbs as well as lower limbs. And from there, you get a graph. And from that graph, you can find out whether the patient is having a heart attack or not. So it is a very inexpensive device, very commonly available, and which is very, very important to diagnose. Without this, you cannot diagnose an MI. Okay, I am not going into details of ECG because at present it would be futile to discuss about ECG. Only thing you should know that ECG is something which is very, very important in diagnostic armamentarium of the ACS patient, acute coronary syndrome patients. So next we will talk about, we will go to details about stress testing. Not only the ECG is important to diagnose an acute myocardial infarction, but we do some blood investigations. Understood? And this blood investigation helps us to diagnose an acute myocardial infarction, especially those cases where we are not very certain, because it happens. The patient is having a heart attack, but ECG may not be diagnostic. Up to 20% of the patients who come to us with a heart attack, their ECG is not diagnostic. That means ECG we are not very sure whether the patient is having a heart attack or not. Okay, in 70 to 80% cases, ECG is conclusive. That means I see the ECG, patient is complaining of chest pain, patient comes to me, I do an ECG, I have an index of suspicion, the patient is mildly likely to have an heart attack, I do an ECG, ECG shows a clear-cut evidence of an heart attack or MI, I am more or less certain the patient is having a heart attack and I start my treatment straight away. Okay, but not all the cases are like that. In few cases, what happens is that patient comes to you with chest pain, but ECG is not diagnostic. That means ECG doesn't show much of a change. And in those scenarios, you can do some blood investigations. Basically, these are enzymes, and estimation of these enzymes are very, very important to diagnose a heart attack. I think I don't know whether you have been taught regarding those things in biochemistry. If not taught yet, probably they will take it all these courses in due course of time. So in heart, what happens is that As I've told that basically what is a myocardial infarction? Myocardial infarction means that myocardium, that the myocardium is the heart muscle. The heart muscle is damaged. And why it gets damaged? It gets damaged because, pardon? It gets damaged because there is a clot formation. See, so this is the coronary arteries. I have told you these are the coronary arteries, right coronary artery, left coronary arteries. There are blockages on the coronary arteries. Sometimes what happens, these yellowish things are the blockages. So what happens, it narrows the lumen. So suddenly what happens is that there is a clot formation on top of these blockages. So if there is a clot formation, what happens is that the blood flow is totally obstructed. It's totally obstructed. Out here, there is a narrowing of the lumen, but the still blood is flowing. Understood? So this is known as stable coronary artery disease. That means patients' coronary arteries, there are blockages, but the blockages is not 100%. That means the blood inside the coronary arteries are still flowing. So whenever the patient is exerting himself, he is walking or running, exerting himself, either physical exertion or emotional exertion, that time what happens, there will be pain, because as somebody exerts himself, his demand increases. So since the arteries are narrowed, it cannot supply the demand, increased demand. So that's why there is a pain on walking or running, on swimming, cycling, there will be pain. But this is chronic coronary artery disease. But what happens suddenly on a fine day, there is a clot formation on top of this block. So what happens? The blood flow gets totally cut off. Like from here, there won't be any blood supply. Like see out here, there is a clot formation on top of these blockages. So from here, there won't be any antegrade flow. Suppose there is a clot out here, till here the blood will flow, but beyond this point, there won't be any flow. That means this part of the myocardium will undergo damage. Understood? Because this part of the myocardium is supplied by these blood vessels. So this part of the myocardium will undergo damage. And this damage starts very early. Within 20 minutes of the blockage, the damage starts. And damage gets completed by 3 to 4 hours. So that's why diagnosing an acute myocardial infarction or heart attack on time is very, very important. Because if you do not diagnose on time, what will happen is that this area of the myocardium, that means heart muscle, they will die because of lack of blood supply. Understood? Because what are these blood vessels doing? They are basically supplying the blood to all these muscles of the heart. So suppose there is no blood supply at all because of clot formation, what will happen? The muscles will die. And heart muscles and brain muscles, once they die forever. It's not like liver. It's not like a skin or your nails on hair. You cut your nails and hairs, they regrow, isn't it, after a few days, because they have the capability to regrow. Same thing with the liver tissues also. Once you cut a section of the liver tissue, it will regenerate, it will regrow. But that doesn't happen with heart and brain. Heart and brain, if it is damaged forever. Understood? So that's why our idea is to prevent the damage as much as possible, as early as possible and as little as possible. So you have to diagnose myocardial infarction as early as possible. Otherwise, the patient will damage his myocardium, that heart muscle, and he will have a disastrous consequences because of that. So to diagnose myocardial infarction on time, we require good history, we require an ECG, as well as we require blood investigations. And in this blood investigation, there are various enzymes which are present. Basically, these enzymes are present in the heart muscles itself. As I have told, heart is basically a muscular organ which keeps on beating. So there are various enzymes which are present inside the myocardial cells. And once the myocardium gets damaged because of the clot, what happens? This enzyme gets released from the cytosol to the interstitium, in between the cells. And from the interstitium, it comes to the blood. Understood? And that you can detect by doing blood investigation. Especially, you can do blood investigations like troponin, blood investigation like CPKMB. So these are the two important blood investigations which you can do to diagnose a myocardial infarction? Troponin and CPK-MB. So if somebody asks you which blood investigation will do to diagnose an acute coronary syndrome or acute heart attack, what would be your answer? Pardon? CPK-MB and troponin. If somebody asks you for the between these two, which one would you choose? Very good. Why would you choose troponin? Now you know everything, isn't it? Even although you are still in first year, still you know quite a lot. Pardon? Mostly? Yeah. First of all, troponin are more specific compared to CPK-MB. CPK-MBs are present in other parts of the, CPKs are present in other parts of the human organs like tongue, intestine, uterus and other places. But troponin, especially cardiac specific troponin, they are localized in the myocardium. So specificity is high. That means if the troponin is elevated, it is likely to be a heart attack. Understood? And sensitivity is also high. That means if the person is having a small heart attacks could be in various magnitude. It could be small heart attack, could be big heart attack. In big heart attack, troponins will be very much elevated. You can see the troponins are very elevated. But if it is a small heart attack also, we can diagnose a small heart attack by doing a troponin, because troponin will be very sensitive. CPK-MB may not rise that much. So you will be under false impression that it is normal. So moral of the story is that if you want to diagnose a heart attack by doing a biochemical analysis, your ideal agent would be troponin T or troponin I. Understood? Rather than doing a CPK-MB. CPK-MB is less sensitive and less specific compared to troponin. Understood? So, and there is I won't go to the details as when it will peak and when it will come to normal. Probably they will take during biochemistry lectures itself. I just wanted to highlight the clinical significance of checking various parameters. So history is very important. Obviously your physical examination, although I didn't say anything about it, but physical examination is also important. Your ECG is important, and along with ECG, your biochemical analysis, especially troponin and CPK-MB. Previously, they should do myoglobin, but myoglobin is not specific at all. So there is no point in doing a myoglobin. Lots of places they do combination of both CPK and troponin. That is also not required. A waste of resources. If you want to do only one investigation, your choice would be troponin. Okay. There are quite fallacies to that also. Because sometimes what happens if the patient is having a chronic kidney disease, then troponin might be falsely elevated. And there are few other conditions also where the troponin will be falsely elevated. I won't go to the details of it, but you should remember that just mere elevation of troponin is not diagnostic of MI. Okay, it's important that troponin should be elevated, but you have to see the pattern of elevation. If the troponin is rising, suppose the patient has come to you now, you are suspecting the patient is having a heart attack, you have done a troponin now after 2 hours, troponin is shown is elevated. So after 3 to 4 hours, you have done another troponin and the troponin is showing a rising trend. That is more important. Understood? So if you do a serial troponin and the serial troponin shows a rising trend, rising and falling trend, that it is absolutely suggestive of a acute coronary syndrome rather than a single elevation. Understood? So typical rise, in the definition also it is there, in the MI definition, there should be a typical rise and typical fall. What comes up should come down also. So likewise, in troponin as well, whatever comes up, it will come up, reach a peak and it will come down. So if you can draw a graph and it shows like that, it is more likely to be suggestive of a myocardial infarction, typical rise and typical fall rather than a single isolated elevation. Because single isolated elevation could be because of other conditions also. That you will learn in due course of time, but that's the moral of the story. So I hope I was able to give some important clinical pointers to us, the diagnosis as well as the history taking of coronary artery disease and acute coronary syndrome or acute MI, and I hope it will be helpful for you. And in future also, I'll be looking forward to taking classes for you. Probably may not be, since I'm a clinician, so probably when you graduate towards your final year, probably that time I would come quite frequently to take classes for you. Until then, it's goodbye from me, and thank you all for your patient hearing. Thank you.